Good evening, everybody. My name is Maurice O'Flaherty. I'm one of the consultants in the Sports Surgery Clinic at UPMC, and I'm here to talk tonight about common runner injuries. So, first of all, a little bit about myself. So, who am I? Well, I've been a consultant trauma and orthopedic surgeon now for 14 years, and I work mainly in the UPMC and Sports Surgery Clinic in Dublin. Um, I did a master's in sports and exercise medicine in the University of Bath in England. And I myself am a keen runner, try and do about 10K 2 or 3 times a week. And I also enjoy going to the gym. So first thing is, why does it matter? Well, if you're anything like me, this is happy you when you're out running. It's not just good for exercise, but also to clear your head. And also, if you're anything like me, this will be you when you're not running or when you can't run because you have an injury or there's something going on and you're ready to kill dead things. So between the two things, obviously running does matter. You wouldn't be here this evening. So if we move on, what are the typical runner injuries? Well, I've done my best tonight to not go into any medical severe speak. This is really just to go over the common injuries, and then Colin's going to talk about the rehab and things like that. So the main things I'm looking at and that I see all the time are Achilles tendon injuries, bone stress injuries, plantar fascia problems, and then of course sprained ankles. So why me? Everybody asks, why has it happened to me? What's going on? Why is it me that's hurting my ankle, me that's hurting my Achilles? Well, the answer is that there's many contributing factors. The first one and the commonest one we see is just literally overtraining or doing too many events and too many things going on and just not taking enough time to take a break and give your body time to recuperate. I have a picture of the trainers there because believe it or not, there is a big difference between some of the trainers out there. As you no doubt know, some of them have zero heel drop, like the Ultras. So you put a little bit more stress on the Achilles, a bit less stress on the knee. Other ones like the Hokas have quite a large heel to toe incline. So some of them are 12 millimeters. They've got a big stability sole. And if you're flipping between one and the other and you haven't done it before, that can lead to injury. The other pictures there, if you transition from road running and you've done road running all your life and you've decided to take up fell running, well, again, obviously these have different demands on the body that can lead to injury if you're not used to them or haven't prepared. So one of the big things that you'll find that I touch on is your gastrocnemius. Your gastrocnemius is attached to your Achilles. And what's the big deal? Well, in a lot of studies in recent times, the gastrocnemius and the Achilles have been interlinked with foot problems and Achilles problems and ankle problems. So they are pretty important, as you'll see. So if we look first at Achilles tendinopathy, what is it and what causes it? Well, you've got the symptoms, mid-substance versus insertional. When do you see me? The first thing is, what is it and what causes it? Well, as you may know, Achilles and Mother Thetis dipped him in the river Styx to make him invincible. He was dipped by the heel, and obviously that left him vulnerable in the heel. The Achilles itself links the gastrocs and the soleus to the heel bone. It's actually the strongest and the longest tendon in the body and can take up to 10 times body weight when it's under tension. It powers your stride, and every step stretches and contracts it. So it is a very important role when you're running. And you may be saying, this guy's crazy. What's he putting up a picture of spaghetti for? Well, I think this is the easiest way to think of the Achilles tendon and when we go on to the plantar fascia. If you imagine that the Achilles tendon is made up of lots of lovely stripes of collagen fibers, when you look at it under a microscope, very much like the spaghetti in this picture. And really, we moved away from the idea that it's a tendonitis. It's more of a tendinopathy. And what do I mean by that? Well, it's more wear and tear. So if you looked at it under a microscope, it'd be more like the frayed rope there on the left. So it has a little bit of fraying, just a bit higgledy-piggledy and out of kilter with its normal self. So what can cause it? Well, tight calves, as we mentioned before, stiff ankles, poor footwear, overtraining and overloading it, all are implicated in it. So the symptoms you may have already know these yourself if you've had it. Lump in the Achilles that itself is tender. It can be worse when you're getting out of bed in the morning. The reason being that Gastrocnemius is usually very tight and contracted when you're sleeping because most people sleep with their knees bent, and then you get up out of bed and stretch everything out in the morning. Pain getting up from rest. If you've got pain down at the heel, it's usually down where it rubs on your footwear. And then in either way, you're usually unable to train as you normally would. So when do you see me? Well, if it's chronic going on for more than 3 months, if it's not improving with stretches or self-management, or if physiotherapy is not working, then we sort of look at the treatment ladder and we decide where you are going to go next on the next rung of the ladder. So what can I do? Well, as usual, take a good history from you, examine you, usually get an MRI scan if you haven't had one done. There's one of the things that we find very useful, which if you have a lesion like that at the back of the Achilles, is a hydrodilatation. Not everybody's suitable for it, but we'd see if you were. And if you are, then we basically strip off the jacket that encloses the tendon and has some of the nasty sort of blood vessels that grow around it and bring in all the nasty pain chemicals. And we strip these off, and that usually gets you back to a more suitable baseline level where you're not as sore and the physio can work with you again. Excuse me. Achilles lengthening are very useful via gastrocnemius release. It's a very small day case that we sometimes do if the calf tightness is the main thing driving it. One of the big things about Achilles and plantar fascia is if you don't get rid of the calf tightness or you can't, then all the other ways of trying to get you better don't work very well. So they're not as effective. PRP injections, some more evidence for these nowadays, very limited, but there are certain times when they work very well. And then, as ever, surgery is a last resort. So the next thing then, bone stress injuries. What do I mean by that? Well, on the left, you can see one picture. This is your heel at the very bottom. And on the right, you can see the same picture, but it's a bit darker. The one on the left is the abnormal one, and that is the one with the bone stress in it. So the areas of white on the left-hand side should not be present in the bone. And what is that? Well, I try to describe it like a crunchy bar. And if you imagine punching a crunchy bar with your knuckle, the chocolate on the outside will be okay. But if you imagine the honeycomb on the inside is a little bit stoved in and a little bit watery. And why is that? Well, it's essentially a bit like in bone. There's an overuse that can be common in runners. It can be for a variety of reasons, usually trauma or overuse. It can be metabolic due to some of your metabolism and your hormone imbalance or things like that, or it can be due to inflammatory conditions. And what happens in all of them is that fluid accumulates in the soft bone or the cancellous bone. That leads to pain, swelling, and it often worsens with activity. And quite often people come in with a limp, things like that. What do I do? Well, we very importantly offload the area that's injured. Quite often, this will require 6 weeks in a walker boot, one of those moon boot you see people walking around in. This usually settles down the acute phase, and in that time, we also check your vitamin D levels, which unfortunately in Ireland we're very low in, obviously with very little sunlight. And we also check your thyroid function test, as that can sometimes be a bit off as well. If we're concerned about your bone density, we'll get a DEXA scan, and sometimes we get a post-injury MRI, but more than usual, we actually find that you're settled down with your time in the boot. And if we've checked all the other things, the more important thing can be to check your biomechanics, your running pattern, and get an orthotic if need be. So moving on, plantar fascia is the next thing. What does the plantar fascia do? Well, the plantar fascia is, believe it or not, very important. It is a shock absorber mainly in the heel, and it transfers force across from the heel to the balls of the toes. And this is made up again of type 1 collagen. And again, I go back to the original picture. We're thinking of spaghetti. So under the microscope, lovely and straight fibers, very uniform. And when you look at a plantar fasciopathy, again, not fasciitis because there's no real true inflammation involved, you see that it looks like the rope on the left and a bit frayed. This too is why anti-inflammatories don't tend to work with plantar fasciitis or Achilles tendinopathy because it isn't true inflammation. So what can cause it? Well, this is one where tight calf muscles are implicated quite a lot. It's very important to assess the tightness in the calves. This is the number one thing that should be tackled before doing anything else for plantar fascia issues. Usually comes on as a result of overuse or activity. If you've got a high BMI and overweight, then you're more likely to develop it. Occupations where you're standing for long periods of time in hard footwear or on hard floors can cause it. A bit less so, your foot biomechanics can be a bit off, or poor footwear can cause it. And the good news is that in the majority of cases, 80% of the time, physiotherapy will settle it down. If that doesn't work, then that's when I tend to see you again. Things we can do: calf releases for a tight calf. Shockwave therapy works very well in cases where physiotherapy hasn't worked well. We don't tend to inject plantar fasciopathy. I certainly don't recommend steroid injection. All the evidence shows that it just gives a short time fix and then it comes back again. And you add to that the risk of rupturing the plantar fascia, so I don't do it. However, there's a bit more evidence for PRP injections, again, in limited cases and depending on MRI appearance, but that's something we sometimes consider. Finally, if you've got to the top of the ladder that we discussed before and you haven't got better, then one of the operations I can do is a keyhole plantar fascia release, done as a day case, very, very tiny scars on either side of your heel, and you get going within a couple of weeks and it tends to work very well. But obviously, again, it's a last resort. Moving on then to ankle sprains. So what do we mean by an ankle sprain? Well, the majority of runners are going to be concerned with a lateral ankle sprain. A high ankle sprain is another type, but in runners, this isn't seen too often. There you can see the lateral ligaments on the left with the ATFL, CFL, and PTFL. And then on the right-hand side, you can see the syndesmosis ligaments. So syndesmosis injuries are also known as high ankle sprains, difficult to recognize unless you have a physio who's really on it and knows what they're talking about. It's very uncommon in runners, so we'll only touch on it, and is usually only about 0.5% of the ankle sprains seen. Excuse me. Much more commonly then, we have our lateral ankle ligaments that are injured. So you see here clearly ATFL and CFL. PTFL nearly always is intact because in the majority of cases when you roll your ankle, your foot's pointing down, and so ATFL and CFL are in tension, and PTFL tends to be lax, so therefore it's not injured as often. So what happens? Well, with an inversion injury or rolling your ankle, a lot of people sometimes hear pop or crack at the same time. You're immediately unable to play on or run on. You get severe pain and swelling, and then bruising develops shortly after. People talk about hobbling about for a few days. Many of you will go to your local A&E department and will have an x-ray taken and be told there's no fracture, sure, on you go. If you're very lucky, you'll get a boot and then you'll see your physio. Sometimes you'll have had an MRI, and usually then when you're not getting better, you'll be sent to see one of us. So what does the MRI tell us? Well, it usually informs me about the lateral ligaments, so the ATFL and CFL. As I said before, PTFL is usually fine. You'll have a synovitis, and this is just a reaction of the capsule around the joint with a lot of inflammation going on. And you'll see sometimes bone edema in the talus, as we touched on before. The bone edema is just bone bruising. And that means whenever you roll your ankle, sometimes the bones hit together very quickly for a short period of time, and then it goes back to the normal position. And that leaves a bit of bone bruising in the bone that itself can be a pain generator. Finally, you look at syndesmosis in the deltoid ligament, but in the running injury, unlikely to have hurt those. So who is this? Well, some of you might recognize Tony Finau. Back in 2018, he was doing the par 3 competition at the Masters, and he got a hole in one on the 7th hole, ran off to celebrate, and then rolled his ankle. I mean, on the left there, you can see a severe ankle sprain. So it can be a significant injury. And with regards to lateral ankle sprains, as I say, physios are wizards. So majority of the ankle sprains like this, functional rehabilitation is the key. We don't just keep the ankle straight and doing nothing. It's very important to get it moving in specific ways, and that's what the physiotherapists are amazing at. Usually referred to me if it's unstable despite physio, you've got ongoing pain, or you're a high-level sports person trying to get back sooner. And in the majority of cases, any surgery or anything that needs done can wait or be managed up until the time is right. So what do I do? Well, one of our best operations that we do is a lateral ligament surgical reconstruction, and it involves two parts. One is looking inside the ankle and clearing out any scar tissue. That's the ankle arthroscopy or keyhole bit. And then the other bit is the lateral ligament stabilization, which is reconstructing those ligaments again. and trying to make them tight. And on a first go, it's generally a winner operation, can be done in the off period of your sport or your activities. Usually done as a day case, you're in and out the same day, general anesthetic, and it takes about an hour to do. And you're a couple of small cuts, and they're reconstructed with special suture anchors that we have. The recovery is fairly quick. So days 1 to 10 is just getting over the operation itself and letting the wound start to heal. From week 2, we get you out of the cast and into a walker boot and get you fully weight bearing in the boot and start specific ankle movement exercises. About week 6, we increase those exercises and aiming towards a return to some sort of sport by month 3. Again, the physiotherapists are all instrumental in the recovery. And in conclusion, then, communication between the physiotherapist and radiologist in any of these issues is key, and they talk to us. All of these are best managed in high volume centres like the UPMC Sports Surgery Clinic. You want to be going somewhere where they see these things all the time. As you probably know, you have stories of people being coddled along for months and not really getting anything done. And it is important, if you think something's not right, just to come and get checked out. Runners' injuries in particular are varied in presentation, and the clinical picture really guides what imaging we request and when we request it. And the images we get then helps the surgeon choice as to what we do. And that's really it. And that's all I wanted to say this evening. If you have any questions, just remember the answer is always that it's science. Thanks very much.